Thank you to Trish and all of you. Thank you. I think I see a few old friends here, so I hope I'm not going to be preaching too much to the choir. I mean, I will be preaching to the choir. You are the choir. But I hope I won't be too much of a heretic or not. But I have to say, most of my life, my clinical life, if I take away all of that stuff, my clinical life has been basically caring for people who lived on the streets, have been living on the streets since 1985. And I had the luxury of, it's like my full-time, because I'm a healthcare for the homeless program like Bobby there, we get the joy of having this as our job. It's not a volunteer thing, or so it's what we do. On the other side of it is I was here many times back in the early 2000s to watch what you were all doing with the street folks in Manhattan and the other boroughs, and it was really fabulous. So I had a chance today to see. I heard you, Scott, in your thing today, and you guys were fabulous. So what you've done with street folks in New York and environs is really incredible, and I salute you for that. And I always feel like it's awkward coming to New York because Boston is so tiny compared to what you are. So forgive us this. We're a 2 mile by 2 mile city, and so we can actually follow people over a long period of time. But anyway, I just thought I'd start you with a story because Joe, our program has relied entirely on Mahasa advocating for the things that we need. And what we feel is a nice relationship is we can be out there on the trenches seeing what's going on and then turn to Joe and say, do something. And then Joe comes up with creative ways to go to the legislature and do things. But sometimes I think bearing witness to what all of you do and making sure that that's at the level of either state or city government is really important. So there are some things I'd love to share with you here, some of which are old and some of which are new. But I'm coming at this as, if you just put I'm a doctor, and I work in a team, and we have a panel of patients, all of whom, for me, lived on the streets, and then all of a sudden they started getting housing. After 20 years of being on the street, nobody was getting housing. And we had this sort of existential crisis as a team. What do you do? We're a homeless program, a street team, and now they're in housing. And our board of directors, which I can show you in a minute, beat us up, saying that our consumer board, that if we had really been their doctor or their medical home for a number of years, just because they got housing, we couldn't stop taking care of them. They thought that would be abandoning them. So when you hear what I'm saying, just come at it from the perspective, I got stuck. These were patients that we were following as a team. All of a sudden they're in housing, okay? But this is an example. So this is a guy named Leroy who our team came to cherish, but we would see him on the street at nighttime in the day. This is him lying in front of one of the ATMs. And he came to our respite program and would clean up and do really well. And I took this picture, he asked me to because he wanted it framed. And his claim to fame was that he looked like Chris Christopherson. Can you catch it here? Okay. And what he had done once, Christopherson was playing at a concert in Springfield, and he hitchhiked out there, snuck his way onto the stage, and said to Christopherson something. And Christopherson was so stunned, he let him play a duo with him. So they played, and that was his. He talked about it all the time. He was actually pretty good too at what he was doing. But anyway, he disappeared, and it always makes us nervous when people disappear. He disappeared for a couple of years. We didn't know where he was, and he showed up in clinic last fall. And he had lost a lot of weight, had been in prison, it turns out. I asked him why. I said, there was a car running in Charlestown. I got in it, tried to drive it away. It turned out to be the city council's car. They were mad. And he would say it just as charmingly as that. But he came in, he had lost a lot of weight, said he couldn't swallow. It turns out this was him coming to our clinic. We have a street clinic at MGH, and that's Sinead, our nurse, who likes him a lot. And he came in, and we were able to bring him upstairs that day, and he had a huge esophageal cancer that had gone metastatic to many places. And we were thinking about that. When he came out of jail, we were able to get him into housing, even though we had to fudge it a little bit because he technically wasn't homeless while he was in jail. But we got him into housing with his ex-wife in a small place. And then he made the decision not to do chemotherapy, not to do all the expensive stuff. In fact, the prognosis was so bad that it was only going to give him at best a few extra months, and he just didn't want to do that. And we thought about it. He decided to die at home. We would visit him several times a day. We would do all the home stuff that you would do normally. And it turns out, even though it sounds like this is another Housing First example of another mortality in housing, when in fact his death was probably the most beautifully orchestrated and run death by someone I've ever seen. He called all the shots. He had all the people he cared about him around him. He had just the right medications, and it was actually a beautiful. This is a picture I took when he was with his wife, and that was his brother, who he hadn't seen in about 20 years. And this is the day before he died, the next morning. So it was a really interesting story for us, and now think of us as healthcare providers, of how the privilege of being able to follow people into their homes is really valuable and really important, we think, and I hope for someone like that is. And so I go back to, this was one of the early dictums that I got from Barbara McGinnis, who, I don't know how many of you are nurses here. Are there any nurses at all? Oh, good, okay, one. Because everything I'm gonna talk about today, I learned from nurses, okay? But Barbara said, you know, you can't wait for people to come to you. If you do, you've already lost. They're gonna end up in the emergency room, because people have got so many struggles going on, healthcare is way down the list. That hurts me to hear as a doctor, because I think that should be your #1 priority, right? But it was true. So most of our program's development has all been, how do you get out to where people are? And the challenge that people going into housing left us is, now that people are in housing, we thought, well, get them into regular care. They should go to the nearby community health, go to wherever. But what we found was they were doing the same thing in housing that they used to do on the street. They would just not take care of that. They would talk about it, but they wouldn't come in for their specialty appointments. They wouldn't come in for other stuff. So we just decided, after our board said you can't abandon them, that we would start taking care of people at home and figure out the rest later. We knew nothing about it. So I now like to think I've had a lot of experience, but no expertise, okay? And I need you all to help us with developing expertise. But this is a picture that Becky Canis stole from me back in a long time. I was just showing it because this was a group of people that we were caring from, and it's a group of, I now think of them as emblematic, but these are guys, these are street folks that live in Boston. We know them all really well. I don't know if you can even see with the lights here, I'm sorry. But they're all sitting in a park on the grounds of our hospital, which is Mass General Hospital. Their average age is about 38 when I took that. I didn't take that picture. When the patient of mine took the picture, there's a woman who took that with a throwaway camera. And and I could tell you the story of every one of those, as all of you who are outreach workers could do. And there's only 2 of them alive today, and they're on the grounds of a good hospital, and they all have Medicaid. Okay, so it's a slide that I always think about as, getting Medicaid is going to be important, but we have to change our health systems to respond to people and know how to address their special needs. And just because they're close to healthcare doesn't mean they're going to get it. Okay, so I often show this in global health seminars to say, if you just look outside Mass General 1 block, you will find the highest crude mortality rate you will find anywhere in the world among a group of people just surrounding our hospitals. So I can show you a little bit, and that turns out to be true. So we started figuring out, can you do primary care and stuff out in the streets? Can you do more than just episodic care? And we've had this great team that it's been fabulous for, we started working the street in '86 when there was a van that went out, but we now have a team that goes out, and we can do things like flu shots, all the stuff that if you crawl into the healthcare provider world, you can do pretty good primary care stuff. And the other thing we get to do is work together. So that's Eileen Riley in the top there, who's a psychiatrist. She works with us and with DMH, and Kendall is a LICSW, and so we get to work together. So it's not like I have to send somebody to the mental health system, or Eileen has to see somebody with a sore throat and send them over to the emergency room. You can work arm in arm. And I found that has probably more radically changed the way I can do medicine than anything I've ever known. Also makes life much more fun. What we did learn when we were on the streets, and I'm all circling the reasons why we needed to get into housing, is this: we realized that these are sick people. They suffer from multiple medical problems, not to mention the severe and persistent mental illnesses, and on our case, 90% of our street folks have an active substance use issue. We actually have 3 people on the streets of Boston who do not smoke, so that's one of our big challenges, okay? So we needed a place to bring them into the imaging and stuff we did. So Mass General let us have a clinic on Thursdays right there in the main, or just off the main entrance. It's this fabulous clinic that they let us have. There's coffee and donuts, and people can come in on that Thursday. It's a separate little waiting room so we can let people be who they are. I took this picture because this is Marianne, who's our nurse, and she's doing triage, and she has vital sign stuff, and she's going to triage them so we can see them in the clinic room. But I took that picture wanting to give you a flavor for it, but I noticed only after I was looking at the picture later on, there's actually somebody asleep under the table, so you get a flavor for what the clinic can really be like. But it's a great spot. It's a place where we realize that you can have a sense of community, and it's in the hospital. We used to think, wow, this is because it's Mass General Hospital. It has nothing to do with that. It has to do with, they'll come in to see Jill or Pat, who sees them outside. If they say, come in, see me in the clinic, they'll come to see the person they're looking for, but they don't like the hospital. They just like knowing where they're going to go, and someone will take care of them. This is just a picture of it. The clinic can be a lot of fun. And this is Jim Bonner, who's our other psychiatrist on our team. He's full-time with us, and he really concentrates on home visits as well as taking care of stuff. But he found that sitting in an exam room didn't work because people were felt a little too confined. So he just sees people in the cafeteria. We thought at first it'd be confidentiality issues with that, but it turned out that nobody seemed to mind. And they'll see people for a minute or 5 minutes or 10 minutes, whatever it is they want. And our folks now wouldn't do it any other way because there's no sign that says mental health, psychiatry, or anything like that. They just see it. And he, who's now in his early 70s and has had a pretty interesting life running ACT teams in mental health centers, wouldn't do it any other way now. So it's kind of an interesting evolution for all of us to do. So let me go back to this group. This group was part of the original group of 119 hardcore street folks who became part of the C-SPEC program. So they were the people that had been on the streets for at least 6 months or consecutively or longer, and most of them had been, as all of your folks, most of them had been on the streets for 10, 15, and 20 years. So when we followed this 119, and this is a statistic I've been sort of updating each year, we've been following for 12 years now, and half of them are dead, even though the average age at the beginning was in the 40s. Another bunch are in nursing homes, which are a huge expense to the system, if you think about it. We did lose 7 to follow-up, so we don't know where the 7 are, but that's not bad over 12 years of 119. So it let us know that at least you could follow people a little bit. But this was the other statistic that Malcolm Gladwell used in his $1 million Murray thing. So this come from Medicaid, from our Medicaid department back in the early 2000s. But they had just that group of 119, 18,000 emergency room visits in a 5-year period. And if you calculate that out, that's about one somebody's in there every second night for 5 years. Then when we looked at what they died from, and this is why I would appeal to you about, as you think of people coming into housing and what we're going to do, it's the medical stuff that is really deadly. So cancer remains our leading cause of death. Okay, and as we see mortality happening in our housing, most of it is from advancing medical things, that diagnoses people had when they're on the street, but the natural history happens when in housing. So please don't be discouraged by high mortality rates when you get people in housing, because I think what you're doing is allowing people to have a dignified death, and it shouldn't be used as something to beat housing first up, okay, which I worry about a lot. If you notice, we only had one person die of heat and cold, which we were confused about. That was really interesting. So this is what we do now. I wanted to show you, this is how we do flu shots now. It's all at home. We've learned that almost everything you do in a clinical office, you can do at home. Okay, and I challenge you to do anything. What can you, there's blood tests, we can even do those at home if you want to. You can't do x-rays, okay, and you can't do, but managing chronic disease and making sure you stay in touch with people, you can do at home. Now the question is, how do you afford that? How do you do it? And what Joe is doing, and I should sit down and let you ask questions in a minute, but we've done it 2 different ways, actually 3 different ways. The primary way we do it is we use our FQHC dollars. And am I talking mud? Does everybody know FQHC here? Okay. So what we did when we're out in the shelters in the streets, if we're a doctor or nurse practitioner or a licensed clinical psychologist or something, if you see someone in what's called a medically necessary visit, you can bill for that. And you don't have to be in a licensed facility. So we just do home visits the exact same way we were doing street visits. So about half of what we do at home now is funded through FQHC reimbursement. Not all of it, half, okay? Now, what is key for our team is we didn't have any way to pay for the non-medically necessary visits, and that's where Joe and Mahasa coming through with the C-SPEC concept was fabulous for us. So all of those folks that we had in that original group, or that original 119, we had part of the home and health league earlier. We had 24 slots of that, and we put those folks into those 24 slots. And the case management was paid for through Medicaid, who gave us the money to pay the housing workers. And so we had to partner with housing stabilization folks and housing programs, which has been a fabulous for us getting together. And it was just like when we worked with medicine and psychiatry working together, we had huge battles because we were trained differently, think differently, but once you learn each other's culture, it's actually fabulous. We had these things when we got into housing, as you can imagine, where we'd have somebody who we were really worried had missed 3 specialty appointments, and we needed to get them to the specialty appointment to make sure whatever was brewing in their lungs wasn't cancer. So that was our most important thing, but the housing worker was working in a world where they had someone who had to move into an apartment that same day, and the priority was get that person into the apartment. So you just have these competing, interesting priorities. So we've been working on how you work those things out, and it actually is fun to finally do. We still do it in teams of 2, by the way, which is another little challenge, but we always send 2 people. It's generally, this is Jim Bonner, our psychiatrist. I took that picture because it makes him look beatific. And he's with Susanna, our nurse practitioner, seeing one of our folks at home who had isolated himself, wasn't coming out, so they wanted to go home and visit him and be sure he was okay. And even though, I don't know why the red isn't projecting, but I put that out. So we're a street team, and over these last 5 years, since 2005, when we first started putting people into Housing First, those are the first street people I ever remember getting housed. We now do over 1,000 homeless visits, just our team, each year. So we're part of your world at home. And the interesting the interesting challenge for us is how do we blend those 2 cultures? Because health and housing are intimate. I think the dance is really elaborate between us, and I think that the outcomes are fabulous if we can keep ourselves humble. I think you have to learn how to manage doctors well, which is very hard, as the nurses will tell you. And we have to learn how to be humble, as I was in another thing just before here, where humility is probably the most important thing here, because most things go at a much slower pace than we want it to go. I think I'm going to stop. There's a lot of other things to talk about, but I think I want to stop and see if there's any questions. And Joe, did I leave anything out on, oh, one last thing, I'm sorry, when Joe mentioned Hughes to Home. So the other thing, this all has catalyzed for us in Boston that we look at, as people get housed, we're looking at them as if there are patients, we will do the housing support, we'll do the medical and mental health supportive service wherever they go. So that means we have to work with all the different housing authorities. The other big partner in our system is the hospital system. And the hospitals are where, when we keep telling them these are the people that have high utilization emergency rooms, they're in the hospital all the time, they have terrible medical problems, you have to stay close to the hospital system. So we have to make sure all of us are part of Mass General, part of Boston Medical Center. And when our folks go to the hospital, we have to be involved in their care, or otherwise there's a big transition between what happens in the hospital and what you know about back at home. And now we also know that the hospital's interests are, these people are using the emergency room all the time, what are they going to do about it? And we have been using our respite program, which is the thing that we could spend days talking about. It's really fabulous, and it's really intriguing, and it's nightmarish, and it's everything else. But it's turned out that we collaborate now with all the emergency rooms in Boston, so when they have high utilizers on a timely basis and they're just frustrated with them, we'll make sure there's a bed at McGinnis House, and we'll meet with them every 2 weeks to make sure we take them into McGinnis House. And from there, using a lot of the programs that's Hughes to Home that Joe was talking about, we can then work hard on getting them into housing. So we use emergency room to McGinnis House to housing as kind of our continuum. So surprisingly, I think of respite now as probably our most important and most utilized housing supportive service. So when somebody's out of control at home, we just bring them into McGinnis House, get things calmed down, and then get them back so the landlord doesn't. By the way, I should have also said, in Boston, we have very few of these wonderful buildings that you have. Almost everybody I'm talking about is placed in a scattered site, single bedroom or a studio somewhere. So you have to go, I have maps I could show you of what we have to do to strategize about that. Okay, am I leaving anything out, Joe, on that Hughes to Home? Or I probably should. You should finish that up a little.
I just wanted, in fact, there was a slide on my presentation that shows this what's interesting is the relationship. A key component is the respite for the people that they're serving in Boston. There's a chart, a utilization chart that a colleague of Dr. O'Connell's, Dr. Yeda, had actually done regarding the Hughes to Home, and it shows a radical drop in utilization of emergency room use. It shows a radical drop in acute care stays. But interestingly enough, a slight drop in terms of the respite component. But the respite component is the very thing that in many respects is keeping the people housed, because it becomes for them a platform, particularly if there's specific issues where they need to return or there's health issues related to that. The respite is a great place for them to go. Jim. No. In terms of who pays for the respite entirely, that's primarily that's part of the health care for homeless and some Medicaid components of that.
Bobby, close your ears here for this. Okay, our respite program, it started back in 1985, and when we had to move to a new building in the early 90s, late 80s, Medicaid agreed to pay for it. Now, there is no way in the world Medicaid's going to agree to pay for these things now with everything going on. But so we're trying to marshal nationally, and Bobby's very much a part of that, the need for respite care. But in Massachusetts, through a special program of Medicaid, our respite program has been paid for. I think it should be part of the continuum of care for every homeless person, and it should be part of CMS and everything else, but it is not. You have to get a creative program. So we could talk about that in another thing.
The cost benefit of that, which is so incredible, is that the first group of, and again, the people Jim was referring to, the top 30 utilizers of emergency and acute services at Boston Medical, Medicaid paid in the first, for a period of 8 months, on average per person, $114,000. They've housed, to this point, it's getting close to 20 in terms of those that they've housed, but immediately post-housing, significant drop in how they utilize the healthcare system. So it's certainly, it's a shame that it's not embraced nationally by Medicaid, because it's certainly a great benefit.
So I'm going to take a second and give Dr. O'Connell some applause.